my name is Dr. Emily Hoskins. I'm an anatomic pathologist at the TVMDL Canyon Lab, and I am really excited to be the third in this series of webinars for Clinical Connections. We've already seen two really great presentations, and I hope that this one will be just as helpful and at the very least spur some conversation about this topic. So just a couple of disclaimers for this presentation before it gets going. The case reports that I am going to be presenting to you are fabricated. They're certainly inspired by actual case reports and events that have happened, but I did make them up for this webinar. And then second, I do not speak for all pathologists. I am relatively new at this. I've been boarded for about a year now. And so a lot of what I'm going to be telling you is going to be things that are my opinion. And so if you ask a pathologist who has more experience than I do or different experiences than I do, they may have a completely different opinion. I am still learning how to be better and do better at this job every single day and just learning all the time. So again, I do not speak for all pathologists. And there are going to be some moments of voluntary interaction for this presentation. It's going to be through the chat, and Mallory has very kindly offered to monitor the chat for me. I know that many of you are probably multitasking as you're watching this, maybe even driving to field calls, and so it's certainly not mandatory, but if you would like to throw your answer into the chat, I would be very appreciative. So just a quick outline for this presentation. First, we're going to go over a very brief literature review regarding this topic. Then we're going to go through some case examples. And when we go through those case examples, I'm going to be breaking down the necropsy report and the different components of the necropsy report and how to interpret those components. And at the same time, going through this decision tree of a pathologist and how providing a clinical history can affect that decision tree. So here is our first interactive moment, and I wanted to ask you about this statement. So providing a detailed clinical history can bias the pathologist and create a less accurate diagnosis. I'm curious if you have never heard this statement, if you were taught this statement in vet school, if you were taught this statement by a practicing veterinarian, or you please feel free to put D in the chat, which is none of this applies to me. So I'll give just a minute or two to put those answers in if you'd like to.
We are getting some B's here in the room in College Station, and then the chat is overwhelmed with A's, a few C's.
Okay, so kind of all over the place. That's super interesting. Thank you so much for sharing that. I was wondering if that was going to be the case. But also seeing, I've never heard this statement, which is, that's good too. So I have a follow-up question for this question, which is, to what extent do you agree or disagree with that statement? And the statement is below in blue if you'd like to read it again.
We are overwhelmed with E's and D's in the chat.
Okay, awesome. So by the end of this presentation, maybe your answer will be the same. Maybe your answer might change slightly, but hopefully it will just get this conversation rolling and get us thinking about this particular topic. So my initial goal of this presentation was I was wanting to do an evidence-based discussion with peer-reviewed literature on how providing clinical history affects diagnostic veterinary pathology. And as I started to do the research and dig into this and make the presentation, I realized very quickly that that doesn't really exist. So I had to make a little bit of a plan change for this presentation and pivot a little bit and said, okay, well, what can we do? So what I decided to do was basically show y'all what does exist in the literature and how it could possibly apply to diagnostic veterinary pathology. And so that led me on a journey to human radiology, to veterinary radiology, as well as to toxicologic pathology. And this is going to be our roadmap, if you will, on this very brief literature review. So the first thing I want to point out is this is not a new question. This is a paper that came out in 1963. This is in human radiology. And this paper is basically bringing up this idea that this is a problem. And I have to read the abstract to you guys because it's just written so well. So the desire of the diagnostic röntgenologist to relate his film findings to the patient's complaints is occasionally frustrated by his lack of information regarding the clinical history. The blank requisition bearing only the patient's name, age, sex, race, and history number is frequently encountered. While some radiologists prefer, at least initially, to inspect films without knowledge of clinical information, others believe that such information is essential to adequate interpretation. So this is super interesting because this is true for pathologists too. I was really lucky in my residency to get to train under multiple different pathologists, and they all had their own style and their own preferences based on how they had been trained. And whenever I would be screening cases with them, some of them wanted me to say the signalement and the history before they looked at the slide. And some of them were like, no, absolutely not. Let me look at the slide first. Don't say anything. I've looked at it. Now tell me the history and the signalement. And so it really was very based on personal preference and how they had been trained. And then the abstract goes on to say, similarly, clinicians are divided in their attitude. Some desire genuine consultation with the radiologist. Others expect an objective report of film findings only without comment concerning their possible significance. So that leads me to this question, which is, in the comment section of the gross necropsy report, I prefer A, strictly objective observations with very little speculation on significance, B, some speculation, but only if there is strong evidence to make the case, or C, speculation is preferred.
We're currently split between C's and B's in the chat.
Okay, cool. Gotcha. Okay, so some speculation, but only if there's strong evidence, and then some say, yes, speculation is preferred. Okay, so I wanted to talk a little bit about the idea of speculation in the comment of a gross necropsy report, and maybe what phrases are used for that speculation. This is a really interesting paper that came out recently in veterinary pathology, discussing the modifying phrases that veterinary pathologists use in diagnostic reports and the veterinary professional's perception on the diagnostic confidence of those phrases. And so this paper was super interesting because this is by no means a standardized practice. Like, we are not trained in residency that this particular modifying phrase means this amount of confidence range. But it did seem like when they went through and did this paper that there certainly were certain tendencies. So they did surveys of about 750 individuals. Some were pathologists, some were residents, some were general practitioners, some were specialists, and came up with this breakdown of what people thought the confidence range was for these modifying phrases. So the first one is diagnostic of. That has a 90 to 90%, 99% confidence range, which is one you don't hear terribly often. The next one is compatible with, indicative of, consistent with, and that is about 70 to 89% confidence range. Suggestive of, suspicious for, that's about a 50 to 69% confidence range, and then cannot rule out, less than 50%. We are really not sure that's what it is, but we can't exactly rule it out, so less than 50% confidence. So just a super interesting paper. Again, this is not standardized practice, but as we move through and talk about the necropsy report and the comment of the necropsy report, keep this in mind. So let's go back to our literature review, back to radiography, human radiography, and we're going to jump ahead to 2021. And this was a narrative review, and the purpose of this review was that it was supposed to appraise the literature pertaining to the influences that clinical history has on the action of assessing the chest radiograph. And this is everything that's been published up to 2021. And I have to tell you, this paper was all over the place. So their key findings: there remains conflicting evidence on the impact of clinical history on chest radiography. Some research suggests that clinical history has potential to influence the reporter in a negative way by limiting their search strategy to a more focused search. The conclusion goes on to say clinical history needs to be assessed appropriately to aid and not stifle accurate image interpretation. Reporters need to be aware of the potential bias clinical history can introduce to their reporting and develop strategies to alleviate this as much as possible. Do they tell us what those strategies are? Do they tell us how to go about this? No, they do not. So for me, this really was clear as mud. And again, that was supposed to be a narrative review of all of the literature that had been put out thus far about that subject. So shout out to my gray horse, who in true gray horse fashion always loves to be covered in mud. So let's bring in veterinary medicine, please, and hear what they have to say about this, right? So this is a paper that came out in JVIM in September 2023, and it's looked at the association between clinical history and the radiographic request and diagnostic accuracy of thorax radiographs in dogs. And their idea was that, okay, we've seen a lot of research of this in human medicine, but we have no data on this topic in veterinary medicine. And they had a hypothesis that diagnostic accuracy would improve when that history was supplied. So they used 30 client-owned dogs with abnormal findings on thoracic rats and confirmed disease. And what I think was really great about this paper and how it differed from the human radiology papers is that they actually used internal medicine workup or cardiology workup to confirm those diseases, as opposed to the human radiology papers, which was more what the radiologist had diagnosed or just overall clinical diagnoses. And so this was a retrospective case control study. There were 60 radiographic studies of the thorax that were randomized and interpreted by 6 radiologists, first with no access to clinical information and a second time with access to all pertinent clinical information and signalment. And the results were a significant increase in diagnostic accuracy was noted when clinical information was provided, 64.4% without and 75.2% with. So their conclusion was that the addition of pertinent clinical information to the radiographic request significantly improves diagnostic accuracy of thorax radiographs, and they recommend it as a standard practice. So that's what veterinary medicine had to say. So we've been talking about radiology, though. So what about histopathology? What's the literature have to say about histopathology in particular? And I actually just learned today that Sam Neill passed away. So rest in peace, Sam Neill. When I made this, I had not known that. So asking about histopathology and where this is in the literature, that brings us to toxicologic pathology. And so this is a specialty that's going to combine pathology with toxicology, the study of how chemicals and other substances affect humans, animals, and the environment. And so these are going to be professionals in universities, government agencies, pharmaceutical and chemical companies, contract research organizations, and consulting roles. And they're evaluating the effects of potentially harmful agents using traditional anatomic and ClinPath techniques, as well as molecular techniques. And so they have their own journal called Toxicologic Pathology. And in that journal, they produce these best practices articles in terms of the best practices used for toxicologic pathology. And there's multiple working groups that are involved in making these best practices. And one of those working groups is the American College of Veterinary Pathologists. And the reason I bring this up is because this is the organization that's in charge of certifying all veterinary pathologists in this country, including diagnostic pathologists. So in this paper in particular, we were looking at informed or non-blinded versus masked or blinded microscopic evaluation in animal toxicity studies. But it also did a really good job of discussing some unique features of histopathology in general. And so with other pathology data, so like with hematology, with clinical chemistry values, those are quantified using calibrated instruments and compared against control samples with known values. When it comes to histopath, this is going to be qualitative or semi-quantitative data at the most. And that data is generated by professional judgment on what is microscopically normal versus abnormal tissue. And that's not really subject to exact quantification. And then that judgment is then informed by that individual's training. So their residency program, the continuing practice of pathology, their experiences, as well as regular continuing education. So in discussing blinded versus non-blinded, scientists from non-pathology disciplines will often say that completely masked or blinded is always going to be better because it's the best means for minimizing all bias. And this idea is based on the assumption that any bias in generating data, including assigning microscopic diagnoses and severity grades, is undesirable. And what's really interesting about that argument is that in a sense, in essence, it is us drawing on our experiences and essentially our biases that allow us to look and determine whether this is a normal or abnormal tissue. And so in contrast, most toxicologic pathologists advocate for an informed or non-blinded initial microscopic evaluation. And that's where the pathologist has full access to the animal's treatment, exposure, dose information, and all that information. And so this view is founded on the idea that properly employed contextual knowledge improves diagnostic sensitivity when assessing product safety in animal studies. And so they concluded that the recommended best practice is that informed microscopic evaluation is the default approach for animal toxicity studies. And the idea behind this is that the advantages of informed microscopic evaluation for maximizing sensitivity outweigh those perceived advantages of minimizing bias through mass microscopic examination. And so that's really what's out there. I wish that we had a lot more peer-reviewed literature regarding this specifically in diagnostic pathology, and I hope that one day it will exist. But in the meantime, that's what I was able to find, and just information for you to just kind of think over and apply to your everyday practice. And so let's go ahead and move on to our case examples. So our first case example is going to be a calf. So this is our TVMDL submission form, which I know many of you are very, very familiar with. For the purpose of this presentation, I'm not going to be going over each individual portion of the form or how to thoroughly fill out the form. I'm going to be focusing on this middle section right here. So for this submission form, we have a 10-day-old male calf. The whole calf was submitted. They have requested a necropsy. And right here, the clinical history is blank. And this is very, very common. We see this all the time with submissions. So here is the necropsy report. And I'm going to be going over kind of the big three components of the necropsy report. And that is going to include the description, the necropsy diagnosis, and then the comment section. And I do want to emphasize that necropsy reports can look slightly different. So depending on if you're working with an academic institution versus a diagnostic institution, and even based on the individual pathologist and the pathologist style and personal preference, these can certainly look a little bit different. But these kind of big three components are going to remain pretty similar. So first, for the description, we're going to have the animal identification and external exam. And so this is going to have the signalment. It's going to have the amount of autolysis or postmortem decomposition that we're able to see from the carcass, how much we think there is present. It's going to have the weight. It's going to have an idea body condition score. And then it's going to have any identifying features. So tattoos, brands, microchips, that type of thing. Then the description is going to go through each of the systems individually and provide a description for each of those systems. And what I want to point out is there are portions of the description that are in parentheses. And this is actually really important because this is differentiating what is objective information in the description versus what is subjective or what is interpretation. And so a true description is going to be a purely objective description of what you are seeing on necropsy. So it's going to use things like location, size, distribution. Is it multifocal versus focal? The margins, is it well demarcated, poorly demarcated? The surface, is it smooth versus rough? The shape, nodular, multinodular, color, and consistency. The idea is that somebody who is not medically trained at all should be able to read the description and be able to picture exactly what you saw at necropsy. And this is different than the interpretation, which is going to be subjective and what you're going to find in those parentheses. So we're going to talk through an example of description versus interpretation with this lesion from a sheep. So this is a lesion arising from the esophagus of a sheep. And you might look at this lesion and you might say, well, that's an abscess. I know that's an abscess because of my veterinary training and my experience. That's an abscess. And you would be right, except that it is possible that if we were to look at this microscopically, we would see that the predominant inflammatory cell in this lesion is actually a macrophage, and it's granulomatous inflammation, and this is actually a granuloma. And that would be a very different pathologic process and suggest different infectious agents than an abscess. And so this is a very sort of straightforward example, but there's a lot of lesions that are not this straightforward. And I think it's really important that in a necropsy report, which is a medical document, that you are able to differentiate what is your objective description of what you're seeing versus what is interpretation? What is the part that is subjective? And I looked at that change and I said, based on my experience, based on what I've seen before, this is what I am interpreting this to be. But I don't know that 100% sure because I haven't looked at it under the microscope. So a description for an abscess would be arising from the esophageal mucosa is a focal, well-demarcated mass that consists of a thick white capsule surrounding creamy to caseous, white to tan, opaque contents. The interpretation of that lesion would then be an abscess. So going back to our description, under the urinary system, I have the urinary bladder mucosa contains multifocal to coalescing red foci. And in parentheses, I have congestion. So I interpreted those red foci as congestion based on my previous experience and what I have seen in that particular tissue before, but there's no 100% guarantee that those red foci actually did represent congestion. That was my interpretation. So then going to the rest of the description, let's look at the respiratory system. So under the respiratory system, it says the cranioventral lung lobes are dark red. And you might read that and you might say, well, that sounds like a bronchopneumonia. And you would be right. You have a cranioventral distribution. It does. But then you go on to say, or I go on to say, the airways are surrounded by and ooze dark red fluid within the cranioventral lung lobes. And that sounds like maybe that could actually be hemorrhage or congestion that's causing that change in color. And then it goes on to say all sections of lung lobe float in formalin. And that means that, well, there's nothing causing enough consolidation in the lung. There's not enough inflammation or other causing enough consolidation in the lung to get it to sink. And so that would make me lean away from something like a bronchopneumonia. So that's what I mean when it's just really important to differentiate like what is objective versus what is subjective in interpretation. In the digestive system, we're usually going to describe the different contents within each component of the digestive system. And in this calf in particular, I say approximately 40% of the jejunal serosa and mucosa is dark red. And this segment of jejunum contains red, watery, opaque fluid. All other portions of the small intestine contain tan, watery, transparent fluid. And I will tell you, just on reading that description and knowing that this calf came in a state of fair postmortem preservation for necropsy, so there was some autolysis, it would be really difficult to look at that change on the necropsy floor and know for sure whether that was due to autolysis or whether that was a true lesion. So that brings me to the necropsy diagnosis. So the diagnosis for this case, regarding the jejunum, I have jejunum open and in parentheses, autolysis versus congestion versus enteritis, which I know is super specific and super helpful. So let's talk about it a little bit more. So why are there so many opens on a necropsy report? And this is the truth, right? So the truth is there are very few gross lesions that are pathognomonic. And when I say this is a hard to swallow pill, I'm actually talking about it's really hard to swallow for pathologists, especially pathologists who are fresh out of residency, because your job in residency was to look at that gross lesion and say what pathologic process was going on and give it a morphologic diagnosis and be confident in that because that's what you did on boards. But then you get out into the real world and the real world is not boards and you realize that you actually can't be 100% confident in most of the things that you see because you don't have microscopes for eyeballs. It would be really great if we did, but we unfortunately don't. So to talk about an example of this, I'm going to go over this for red, but this can be applied for lots of different color changes. But red can mean a lot of things. So these are lungs from a llama, and you can see we have this kind of locally extensive area of red discoloration, dark red discoloration that appears to be unilateral. And this change could represent acute or chronic congestion. It could be hemorrhage. If this was a tissue that had epithelium, it could be erosions versus ulcerations. It could be inflammation. It could be necrosis. It could be a special type of necrosis, which is where you have a lack of blood flow leading to necrosis, which is called an infarction. Or it could be hyperemia, where active blood flow into the area, or it totally absolutely could be autolysis. So in this case, this was histologically confirmed to be congestion, but just based on looking at this grossly, it would be really hard to tell that for sure. Now, there are some exceptions to this. right? And this is what we refer to as gross out cases. And basically what that means is we can do the necropsy, we can look at what we're seeing grossly, and we can be completely confident that we know what pathologic process is going on without looking at it under the microscope. So some really good examples of this are if you have a dog and you have this hemorrhagic tumor in the right auricle, and then you have a spleen that has all of these nodules on it, you know that that's a hemangiosarcoma. Like, you know that's what's going on. You don't have to look at it under the microscope. Another example of this would be if you have a bovid that you have opened up and you see this beautiful shag carpet fibrin lesion covering the heart, you know, in the pericardium, you know that that's a traumatic reticulopericarditis. You don't have to look at it under the microscope to know that that's what's going on. But I do have to say that those are the minority of the cases, right? Those are going to be if you get lucky. And so sometimes it's helpful to think about a necropsy as a systematic way of collecting tissues that's meant to guide ancillary diagnostics. And if you're really lucky, you can get a definitive diagnosis from a necropsy. So that brings us to comments. And so the comment for this CAF says, a definitive cause of death is not identified at necropsy. However, the changes observed in the jejunum may suggest, remember those modifying phrases we talked about, enteric disease, and would require microscopic examination for further characterization. So I am recommending histopath to try and figure out better what is going on for this case. And then I want to point out this section right here that's italicized. This is important in that we keep our fresh tissues for 14 days and our formalin fixed tissues for 21 days. And so after the necropsy, we have collected those fresh tissues and we're holding them for 14 days. If you are wanting to request a test that was not requested on the submission form, you need to do that within those 14 days. Those fresh tissues are then going to be disposed of. So for this CAF, this is the CAF that came in with no history. I went ahead and I recommended histopath to try and clarify what was going on. So how would this have looked different if we had had a little bit of clinical history to go along with this submission? So let's go back to our submission form. Again, we have a whole calf submitted for necropsy, 10-day-old male calf, same calf, but this time in the clinical history, we have found dead this morning after several day history of diarrhea. So this isn't a long history, right? Like, it's barely a sentence, but this is helpful for several reasons. So the first is that it gives us a little bit of an idea of a postmortem interval. So we know it was found dead this morning, and we know that it was at least being observed enough that we were clinically seeing diarrhea for several days prior. So we know that this was not a body that was sitting out for several days in a pasture before we got it. So why is postmortem interval important? There's a couple of reasons. There are certain tests that are no longer accurate after 24 hours postmortem. And some examples of that are prussic acid or cyanide toxicity, as well as rumen pH. So the pH fluctuates after death to the point that if it's after 24 hours, we are no longer able to, for sure, diagnose rumen acidosis or things like that. And another really big reason is autolysis versus true lesions. So if we have a case and we're seeing changes on the floor and we're looking at it and we're like, oh man, like, I'm really unsure if this is just change from autolysis or if this is actually a true lesion, it can be really helpful to have an idea of how fresh that carcass is, because that can make us lean more towards, oh, maybe that actually is a true lesion. And that is going to affect what ancillary diagnostics that we're going to recommend based on what we saw on necropsy. And then finally, with field necropsies, timing matters both before and after receiving the sample. And what I mean by that is if you're doing a field necropsy and you're sending in fresh tissues, when we get those fresh tissues, they are going to go into a refrigerator and be stored there. But postmortem bacterial overgrowth and decomposition are still taking place even during that time of shipment, even during that time storing in the refrigerator. And so if you are suspecting a bacterial etiology and you are wanting culture, I do recommend going ahead and just requesting that culture right off the bat to get the best results out of that testing. Okay, so we had the calf with no history and we recommended histopath. And so this calf with history is actually going to change several things. So since I have a history of clinical diarrhea, I'm actually going to recommend histopath. I'm going to recommend culture. I'm going to recommend a calf diarrhea panel, and I'm going to recommend a fecal egg count. And I'm going to be recommending that in my comment of that gross necropsy report. So it is getting started right off the bat. So let's talk about the histopath results for this calf. So the first slide I'm going to show you is going to be a small intestine, not from this calf, but it is going to be from an animal that was euthanized and then immediately necropsied. So very, very little autolysis has happened. And this is what this can look like. So we have really, really nice differential staining of our pink and purple of our H&E stain. We also have really nice preserved architecture. So you can see our nice villi right here. And then within those villi, you can see populations of cells, which are leukocytes, that if we were to zoom in a little bit more, we could actually tell what those leukocytes were and what processes were going on. Now I want you to look at this and remember this and compare it to the small intestine from this calf. So it's a completely different ballgame, right? So we have a loss of differential staining. We're not seeing that nice contrast of pink and purple. We're getting this kind of faded out pink color. We have also kind of lost our architecture, right? It's really hard to distinguish our villi. And then also these cells that were in the lamina propria, they're not very well preserved. So even if we were to go in a little bit closer, it's really hard to tell what type of leukocyte we're actually looking at. And what makes this really tricky is that you can see this change with autolysis, or you can see a very, very similar change with necrosis. And so it can be really hard to piece out sometimes. Am I looking at autolysis, or am I looking at this change due to necrosis? And so in the case of this calf, if we look a little closer, we also have bacteria that are within these areas of changes. And they're in the villi. They're also going down a little bit into the crypts. And if we do a gram stain on those bacteria, they are gram positive. So they're purple, and it looks like they are primarily gram positive purple rods. And again, this is still tricky because gram-positive rods could suggest maybe Clostridial species, and that is a species that you can normally see in the intestine, or it can cause a bacterial enteritis. So we're trying to balance, okay, is this autolysis with just normal bacterial overgrowth, or is this necrosis and we have an actual bacterial enteritis going on? And so the turnaround time for histopath is about 2 to 5 days. This can vary just a little bit with special stains and some other factors, but in general, about 2 to 5 days. And here we have what we just discussed, which is we have autolysis versus necrosis. We're not entirely sure, and we have gram-positive rods present in those areas, and maybe inflammation, depending on if we could actually figure out what those leukocytes were that were not well preserved within the lamina propria. And so based on that, I'm going to go ahead and recommend culture to see if we can better characterize those bacteria that we were seeing. So the turnaround time for culture is 2 to 7 days. So take a look at how many days could potentially be going by as we're doing this testing. And what's going to happen is we have 3+ mixed bacterial growth. And a big part of that is because of how much time has passed and the postmortem bacterial overgrowth that could have occurred. And unfortunately, that's going to lead to inconclusive results because there's no way for us to say, is this just bacterial postmortem overgrowth, or could there potentially be a bacterial enteritis? And so we're not going to get a good answer on this case. Let's compare that to a calf that had that clinical history of diarrhea, and we started those other tests right off the bat because of that history. So histopath, again, we have a turnaround time of 2 to 5 days. We have the same findings on histopath. We've got autolysis versus necrosis, but this time I'm going to favor necrosis a little bit more and a possible bacterial enteritis because of that clinical history of diarrhea in combination with what I saw on the floor. The calf diarrhea panel has a turnaround time of 1 to 4 days, and with that test, we can rule out coronavirus, rotavirus, and cryptosporidium. The fecal egg count has a turnaround time of 1 to 2 days, and with that test, we can rule out endoparasites. The culture, again, has a turnaround time of 2 to 7 days, and this time on culture, because we didn't have as much time passing by, we got a culture result of Clostridium perfringens 3+ and E. coli 1+. And in the context of our clinical history, of what we saw in necropsy, of what we saw in histopath, I can be more confident that we have a true bacterial enteritis going on, and we can go ahead and type that Clostridium and do toxin detection and get a definitive answer for this case. So I hope that helps walk you through just a little bit of how the thought process can change just by providing just a very, very brief history and how that can change your overall results. So our next case example is going to be a cat. And this is a 1-year-old domestic short hair male neutered cat. They went ahead and requested a necropsy and histopathology on the submission form. And we do have a little bit of clinical history where it says concern for toxin exposure. So let's talk a little bit about toxin cases. So when you have a case you're suspecting toxins and you're needing to submit tissues, and it's a field necropsy, which tissue is least likely to be diagnostic in a toxin suspect case?
We're getting some B's. And
Bees,
A.
okay. Got an A, okay, awesome.
Mostly B's.
Mostly B's, okay, cool. So I'm agreeing with the majority for lungs. There's always exceptions, but in general, the samples that are best if a toxin ingestion is suspected is going to be stomach rumen contents, liver, kidneys, the brain, and then adipose tissue. Adipose tissue is tricky. I feel like it's one that tends to get forgotten. And so I have bromethalin up here because it causes neurologic signs. And so you would think that it would be the brain that would tend to have most of that toxin stored, but it tends to actually be stored in the adipose tissue. So a little bit of a tricky example, but a good one to keep in mind. And then when it comes to submitting tissues for a sudden death case, if you're doing a field necropsy and you need to submit tissues and you're limited on how many tissues you can submit, the systems that are most likely to be involved in sudden death cases are going to be cardiovascular, respiratory, neurologic, and then plus minus gastrointestinal for large animals. There's always going to be exceptions to the rule, but in general, this is a pretty good rule of thumb to follow. So let's go back to our cat. So this is our necropsy reports. And so we have the whole body of a brown tabby male castrated 1-year-old domestic short hair cat. Is submitted in a state of good postmortem preservation for necropsy, so didn't note a lot of autolysis on this one. We have the weight. There's a moderate amount of subcutaneous and intra-abdominal fat, so pretty good condition. And then the respiratory system, all long lobes are mottled dark red and they palpate with crepitus, and all that means is that when I'm feeling the lungs, it feels like the lungs are full of air. And sections from all lung lobes float in formalin. The heart weighs 16 grams, and it's always good to get a heart weight on cat hearts because you can rule out hypertrophic cardiomyopathy as a cause of sudden death. And then we have the description of the GI components and contents. The liver has some multifocal patchy regions of pallor within all the liver lobes, and the parenchyma is slightly firm and expanded, and the lobes have rounded margins. And so for a necropsy diagnosis, I've got lungs open, parentheses, congestion versus hemorrhage, and then liver open, parentheses, hepatic lipidosis versus inflammation versus necrosis versus other. And so for histopath results, we did have histopaths requested on that submission form, so go ahead and get that going. And the way that things are trimmed, usually one of the very first tissues that we end up pulling up first is the brain. And so this is this cat's brain, the cerebral cortex, and usually the brain is mostly a lot of pink. In this brain, we're seeing a lot more regions of purple than we would typically be seeing in a brain. And so we're going to take a little closer look at why we're seeing all this purple. And this is the reason. So these are the blood vessels inside the brain. And we have this population of inflammatory cells that are surrounding that blood vessel that are mostly made up of lymphocytes and macrophages and a few plasma cells. And so this is actually going to be an encephalitis. And it's an encephalitis that we really don't know exactly why it's there. And so when that happens, that's usually going to be a phone call. So this phone call, I was able to get some additional history. This was a barn cat that was acting weird and neurologic before dying, which is why the owners suspected a toxin. So this is problematic, and it's problematic for a couple of reasons. But what are two big zoonotic rule-outs? There are obviously a lot of causes of encephalitis in a cat, but what are two big zoonotic rule-outs that would be important to keep in mind for this case?
We're getting rabies.
Uh-huh.
So lots of rabies.
Lots of rabies. Love it. Yep, rabies should always be on that list, right? And if we're seeing an encephalitis, it should really be on that list.
We have one avian influenza. We have a toxoplasmosis.
Oh, yeah, toxoplasmosis. Excellent. Okay, and then we got an avian influenza parasites. Nice. Okay, so again, there's lots of causes that could be causing this encephalitis, but the two that I was thinking about were rabies and highly pathogenic avian influenza. So just as either an FYI or a reminder that whenever they looked at distribution of lesions of HPAI in domestic cats, non-suppurative and necrotizing encephalitis was one of the main lesions that they saw. So I'm keeping this presentation pretty light, but I do have to emphasize the serious repercussions that can happen regarding providing a clinical history and biosecurity. And I'm not just talking about exposure to the pathologist, I'm talking about all involved sections. So receiving the necropsy technicians and staff, shipment, if you're shipping out to other referral labs, and then of course all of our ancillary diagnostic sections, BAC-T, virology, molecular, serology, analytic chem, climpath, and I haven't mentioned all of the sections. Our receiving team is trained really well to look at the histories that come in and to look for keywords that might suggest zoonotic agents. But if they have no clinical history to go off of, how would they have any way of knowing, right? So I know that a lot of times we don't have the history to go with cases, but in terms of purposefully choosing to omit history, especially in a case that could potentially have zoonotic repercussions, that could have some pretty drastic consequences. So we're going to wrap up this presentation pretty soon, if you're still with me, and we'll get into key takeaways, but I wanted to leave you with this photograph that I took of a pretty recent case that I had on the floor, and this was a dog that came in with no clinical history, and I had these changes in the small intestine where I have this dark green to black segmental change in the small intestine, sometimes fairly well demarcated. And if this dog was more rotten, this is absolutely a change that you could see with severe autolysis. This dog happened to be really fresh. And so because of that, it made me lean towards that this was actually a true lesion with potential necrosis. I haven't gotten the histopath back on this, so I don't have a for sure answer for you, but that's just kind of the thought process that I had on the floor with this one. So some key takeaways for this presentation. We don't have data and peer-reviewed research regarding clinical history and bias for diagnostic pathology. I hope that that will change in the future. So for now, this is a decision that clinicians just have to make for themselves. And if you have any questions about that or you want to discuss that, I really encourage you to talk to your pathologist or veterinary diagnostician that's on the case. We are absolutely happy to talk to you about questions about history or testing, and that's why we're here. We're here to help and serve the people and the animals of Texas and beyond, and to help you help your clients as best that we can. And it's what we're called to do, and truly why we're here, and we would love to talk to you. So I would be happy to answer any questions. If you want to reach out to me after the presentation, this is my email right here. Please feel free to do so. This is a picture of me and my family. That's my husband and my daughter. And we are in Paladuro Canyon, which is absolutely gorgeous and amazingly 8 minutes from where I live now. It is the second largest canyon in the United States. And so I highly recommend coming up and visiting. If you ever can, because it is just beautiful. So I thank you so much for your attention and your time, and I hope that you found this helpful, and I'll be happy to answer any questions. Thank you so much.